check for it.
All right, just waiting for confirmation. I believe you are live. Good evening. This is United Medical ACO Diabetes Program, and my name is Kamal Arkan. Today is May 26, 2021, Wellness Wednesday, and your favorite diabetes team is on. And I'm going to ask each of our members to introduce themselves. Donna, we can start with you if you like.
Sure, thank you, Kamal. Good evening, everyone. My name is Donna Gonkel, and I am the Director of Clinical Integration, so I oversee our wellness programs.
Dr. Hundal, do you want to go next?
Hi, this is Ripu Hundal. I'm endocrinologist in Newark area, also working in Middletown as well. So happy to be here.
And I'm Amy Wilcoxon. I'm a dietitian and diabetes educator with our UMACO diabetes program.
All right, thank you. And I'm gonna start sharing my PowerPoint. Dr. Handal, would you like me to give you access to share? Move the control the mouse, or would you like me to just click from my side?
Yeah, you can click. It's easy. It's fine.
All right, so
I'll let you know.
Okay, that sounds good. And 4 of our members are, of course, present here tonight. We have Tim McCoo and Jacqueline Tomasetti, who are also part of the program. So just so that we would be able to know them. And we'll start. Today's panelists will be Dr. Handal, and Amy Wilcoxon. So we are going to discuss, as usual, the diabetes, right? So from here, Dr. Handal, I believe you are taking over. So you just need to
All right.
let me know. All right.
Sure. Thank you very much. So I think this is just a continuation of from what we left from previous presentation. If someone has listened to the previous one, we discussed about general, like how do you diagnose diabetes, what is type 1 diabetes, what is type 2 diabetes, general guidelines. So we are doing in steps so that you have better understanding of how to diagnose, how to treat, what are the complications. So this is whole part of series of presentations. So today I'm doing part 1 of the medications which we commonly use in patients with type 2 diabetes. So as go back, Kamal, So I repeated this last time too. So in general, our goal is the A1C, which is average blood sugar readings over the last 3 months, should be below 7. The lower you go, better it is, but provided you are not causing any frequent hypoglycemia in the patient, so then it's not good, then you need to back off. In general, pre-meal blood sugars, if they are being checked, anywhere from 80 to 130s, 2 hours post-meal blood sugar, less than 180, even according to American College of Endocrinology, maybe less than 150 is a better number. So there are oral medications, and then there are injectable medications, which are not insulin, and then the insulins. These are the 3 different things that we use. And then we will discuss briefly about all these medication one at a time. So the basic step is diet and exercise. That's very, very important in any person with type 1 or type 2 diabetes. Then there are a lot of oral medications available. Luckily, in 1990s, we used to have just the first 2, which is metformin and sulfonylureas. These were the only one. Then after 1990s, in 2000 onwards, then we have a huge class of medication. Actually, thiazolidinediones was also available in late 1990s. Then we have new class of medication, which we'll discuss slowly as we go through the presentation. So next slide. So to just briefly go over with the defects in diabetes, so you understand better where these medication works and how they help to improve the blood sugars. So there are numerous factors which leads to high blood sugars in the blood. On the top one is the pancreas, which secretes insulin and also secretes another hormone called glucagon, which is a counter-regulatory hormone. So by that, it means if the blood sugar drops low, then the glucagon secretion is supposed to go up to help bring the blood sugars up. So in patients with type 2 diabetes, they have decreased insulin secretion and they have inappropriate glucagon hypersecretion. So the glucagon is being secreted at a higher level, so that indirectly leads to higher glucose production through the liver. Then at the if you go in clockwise, then the next is the brain. The brain sends important signals to the pancreas and helps with improving the insulin secretion. So there is some defective, you can say, neuronal signals to the pancreas, which leads to deficient insulin secretion. Then the third one is the muscles and the fat cells. So normally when we eat, the blood sugars are taken up by the muscles, the fat also, the fat cells take up the fat, free fatty acids, and stores over there. But in people with type 2 diabetes, they are more insulin resistant. So the glucose is not going into the muscles, and the fat cells, instead of storing fat, they are releasing inappropriate levels of free fatty acids, which impair the action of the insulin. Then in the kidneys, normally kidneys will excrete excessive amount of glucose in the urine. In people with diabetes, actually it's reabsorbing glucose back into the system. Rather than dumping out, it's getting it back into the bloodstream. So that leads to high blood sugars. The next one is the liver. When we are overnight sleeping, liver is an important organ because then our brain still needs glucose. So the liver tends to convert the stored glucose during the daytime, which is called glycogen. It converts into glucose and releases back into the blood for the brain to utilize the glucose for metabolism. In people with diabetes, the liver is inappropriately active. It just keeps on making more glucose even when it's not needed. So even in the early morning hours, it makes too much glucose. After meals, usually it shuts down in a normal individual, but in patients with diabetes, it keeps on making more glucose. Then the last one in the stomach and in the intestines, these are called incretins. These incretins are the hormones which are thought to stimulate the insulin secretion and decrease glucagon secretion after we start eating. In patients with diabetes, these hormones are deficient or the body has more resistance to these hormones, which leads to the problem with blood sugars. And then also there is a quick, in the gut, in patients with diabetes, there's a quick absorption of the carbohydrate sugars from the meals. So rather than giving some time for the sugars to go up, there's a quick absorption of the food that leads to rapid increase in the blood sugars, and the body is unable to cope with it and make sufficient amount of insulin. That's why the postprandial after meal blood sugars goes high. So it's a multiple defect. So looking at this slide, please remember, I think last time also, I think we discussed that people say, okay, why I need only one, why only one medication cannot do its job. The reason is right here, because their multiple organs are defective. You have to use medication which are working in different organs to bring the blood sugars down. So the next slide, it just tells us where these medications work. So we will be telling more in detail, but I will just quickly tell over here. So in the terms of pancreas, these are insulin. Obviously, if the insulin is not being made, we give insulin from outside. Then these are sulfonylureas, glanides. I will talk about it. These are medication which helps to secrete more insulin secretion. Then at the level of the brain, There is a medication called dopamine agonist. They help to improve the neuronal signals to the pancreas. At the level of the muscles, fat cells, they are thiazolidinediones, the most common medication called pioglitazone that works to improve the insulin sensitivity. At the level of the kidneys are the new class of medication. These are called SGLT2 inhibitors, which helps to dump extra glucose in the urine. At the level of the muscle liver, the most commonly used drug called the metformin that works over there. Then in the gut is these are called GLP-1 receptor agonist or DPP-4 inhibitors. They work and helps to augment insulin secretion. And then in the stomach, in the gut lining, these are called the alpha-glucosidase inhibitors called the AGI. They help to slow down the breakdown of glucose in the stomach. So it takes a longer time to digest, and then gets quickly absorbed into the system, so the blood sugars don't go that high after the meals. So we are going to talk about these different medications slowly so that you have a better understanding of how these medication works, what are the side effects, and where to use the medication. Next slide. So these are called the most oldest drugs commonly used is the insulin. These are called Secretagogues, means it augments insulin secretion. This class of medications, they're called Sulfonylureas. So you must be familiar with these medication if somebody has diabetes, like glybride, glipizide, glimepiride. These are the most three commonly used drugs, which basically works by increasing the insulin secretion. So it's even at basal means even if you're not eating, it will help to increase the insulin secretion, and then it augments insulin secretion after we are eating. So what can be the side effects? The side effects will be, because this medication basically augments more insulin secretion. So for example, if you miss your meal, it will lead to low blood sugar reaction. So if your blood sugars are running low more often, what we are going to do? We're going to eat more, bring our blood sugars up. So weight gain is commonly associated with this medication. These are the two main things that we are, especially in the elderly population, we try to avoid this medication because of this problem. And then really the patients with sulfa-allergies can have sometimes, although it's not common, can have allergic reaction to these medications. So this medication, basically how it works is the augmenting insulin release. So insulin, how it's cleared from the body is through the kidneys. So if anybody has defective kidney functions, they will be at more risk for low blood sugar. So please talk to your family physician or the endocrinologist, whoever is taking care of your diabetes, to see what your kidney functions are. If kidney functions are declining in stage 3, stage 4 kidney damage, then usually it's not a good idea to be on this medication. So that's very, very important. Low blood sugars can sometimes, patients have seizures, they can fall down, break a bone, hit their head, have a brain bleed. So again, it has to be taken very seriously. Next slide. Out of these medication, the glybride is the oldest one. It still is even after it's being metabolized by the liver, 50% of the metabolites has the capacity to cause low blood sugars. So that can cause low blood sugars in elderly population, especially in light of their renal functions, which are compromised. As we age, our kidney function tends to decline. So if somebody, your relative or yourself, elderly person is on glybride, probably you should talk to your providers. And if you have to take these class of medication, it's better to take glipizide or glimepiride, where 90% of the metabolites coming from the liver are actually metabolically inactive, means they do not do anything. They do not cause any low blood sugar. So that's very, very important. Next slide. The other class of medication is called maclidinides. This is another class of medication which helps to augment insulin secretion. There are two of them are available on the market. One is called repaglinide and the other one is called the netiglinide. So this is like, if you remember the names, they are also named as Brandon or Starlix. They were the trade names. Now it's generic. So one good thing about these medications are they are shorter acting. They do not work for long period of time. So they're usually given with each meal, just at the start of the meal, and it works for 3 to 4 hours, then it's out of your system. So in people with advanced kidney damage, we do not use the first class of medication, which I just explained, called the sulfonylurea. We can use this class of medication, the second class, which are shorter acting, and it works only for 4 or 5 hours and has less risk for hypoglycemia. Again, the side effects can be weight gain and hypoglycemia, depending on how low the blood sugar is. It's also the repaglinide is converted to inactive metabolites in the liver, and less than 10% is excreted through the kidneys. So that's why it can be used even in patients on dialysis. So even in advanced kidney failure, we still use it. The netiglinide has some more active metabolites, but most of these drugs we do use in patients with advanced renal insufficiency. And again, with this medication, it is to be used within 5 to 30 minutes before the start of the meal, and to be used only if you are eating. If you're not eating, don't take this medication before that meal. Next slide. So here, this is shown over here. This is one of the drugs called the repaglinide. As I explained earlier, the effect is shorter lasting. So here there are different doses of the repaglinide shown in increasing strength. So it's just taken before meals. It helps with increasing the insulin secretion, and it works for 2 to 3 hours, at the maximum 4 hours, but then it's out of the system. So it has low risk of low blood sugar. Next slide. So next class of medication is biguanides. That is the most common, oldest drug called the metformin. There is only one drug in this class. This basically works on the liver and helps to decrease the liver production of the glucose. As I explained earlier, liver is very active. It's making high amounts of glucose, which is a very common reason for high blood sugars, especially in the morning. So basically, the metformin works on the liver, helps it to become more sensitive to the effect of insulin, as insulin tries to shut down the liver production of the glucose. So it's usually given twice a day. The main side effects is the gastrointestinal GI side effects. So it can cause some nausea, some diarrhea can happen. It's weight neutral or maybe a little bit weight loss, but does not cause weight gain. Always take with meals. If you're not eating, don't take it on an empty stomach. You start slowly with 500 milligram, maybe even once a day or twice a day. The maximum you can go up to is 2000 milligram. There are also some doses available, 850, people use it 3 times a day, but usually once you are between about close to 2000, that's the maximum effective dose. No point in going higher on the liver. Very, very important. Anybody with hepatic dysfunction, means liver problems, kidneys problems, anybody with active congestive heart failure, this medication should not be used because it can increase the risk of what is called lactic acidosis. There's a buildup of acid in the blood, which can cause serious problems. Patients can start throwing up, nausea, vomiting, can be seriously ill, and people can also die from it. So it's very, very important to not take it lightly. But in general, this has been used for a long period of time, one of the safest drugs. If the renal functions tends to decline, that's called the GFR. If it's less than 45, then we can go up to the maximum dose of 500 twice a day. And if the kidney function goes below 30, which is stage 4 kidney damage, then this medication should be stopped. Anybody with history of congestive heart failure but is stable, they can continue metformin.
So, Dr. Just so that because I see some of these in some of our patients, and because I'm not the clinical person, so when I see the GFR, when we look at some of the patients with diabetes, if they have any chronic kidney failure. So this is the indicator for us, right? The GFR.
Yes, right. This is the indicator of the kidney problem. So, but still previously it used to be if the GFR below 50, people used to stop the metformin. That's no longer true. So the FDA 3-4 years ago changed these indications. So now it can be used if the GFR goes below 45, then typically dose is 1000 milligram twice a day. That should be decreased to 500 twice a day. And if the GFR goes below 30, then stop the metformin. Then at that level, then it can increase the risk of lactic acidosis. So as such, there's a lot of people read over the internet, oh, the metformin caused my kidneys problems. Metformin per se does not cause kidney problems. It's on top of something else. Like people are taking metformin, so they develop stomach bug, constantly throwing up, nausea, vomiting, they get dehydrated, they continue to take metformin, kidneys worsen, then it can make them more prone for lactic acidosis. So for some reason, if you are sick, not eating properly, throwing up, please stop your metformin during those days. So the next one is called the Thiazolidinediones. This is a class of medication. 2 of them are available. Most of the time, only the first one is now being used. It's called the pioglitazone, used to be called as Actos with the trade name. And the brand name is Actos, and the rosiglitazone, which is used to be called Avandia. The second one, the rosiglitazone, because of a lot of controversy with the heart problems, is no longer being used. So mostly people use pioglitazone nowadays. The main medication, how it works is it enhances the action of the insulin in the muscles and fat cells. So this is like an insulin sensitizer. Like metformin is an insulin sensitizer at the level of liver. These are at the level of muscles and fat cells. So they become more sensitive to the effect of insulin. They can suck in more sugar. They can suck in more free fatty acids and store the fat where it belongs. And then indirectly at a higher dose, it can also reduce the liver production of the glucose. The main side effects of these medication, one good thing about this also medication is like metformin, they do not cause low blood sugars. So the metformin does not cause low blood sugars. This class doesn't cause low blood sugars, but the previous 2 classes of medication, which I showed, the sulfonylurea and the maclidinides, they can cause low blood sugars. So with the thiazolidinediones, the main side effects is it can cause fluid retention, the way it works. So this usually happens when people were using inappropriately very high doses of these medications. So nowadays, especially in elderly population, we use the minimum possible dose of 15 milligram. The maximum dose is 45 milligram that usually you can use in the younger population, but just be careful. It can also lead to some weight gain because of the increase in the plasma volume. There can be some anemia. There was some concern for bone loss, which is seen in less than 3% of the population. So if somebody is on this medication, there's unexplained bone loss, then should stop the medication. This should not be used in patients with history of congestive heart failure because it can cause water and fluid, like salt and water retention, can worsen their congestive heart failure. So that is very, very important. There was earlier some rare risk of bladder cancer. Now the FDA has come up with that may not be true. They have done further studies. But again, if somebody has history of bladder cancer, then maybe avoid the medication. Next one. So the next class of medication, these are called alpha-glucosidase inhibitors. So as I explained earlier, in patients with diabetes, there is a rapid absorption of glucose from the stomach. So the blood sugars quickly goes up. The body cannot compensate for that, but a normal person will immediately make a lot of insulin and keep the blood sugars quickly bring it down. But in individuals with type 2 diabetes, there is a deficient insulin secretion, so they cannot do it. So these class of medication, which I is in front of you, they basically work by blocking this enzyme, alpha-glucosidase, so that delays the breakdown of sugar from complex carbohydrates to simple sugar. So it takes a longer time to digest it, So thereby, it takes a longer time for the sugar to get into the system. So there are two main medications. One is called the acarbose, that is the brand name is the Precoz, and the other one is called the Miglitol, and it's also called Glycet. So these medications are again taken with the first bite of the meal. If you're eating, you take it. If you're not eating, then don't take the medication. So that's very important. These are very good drugs, but mostly not in favor because of the main issue is the GI side effects. So especially at the higher dose, it can cause a lot of like flatulence problem, gas problem. So then people are not able to tolerate it. But usually the dose is 25 milligram with each meal to the maximum dose of 1000 milligram with each meal. Anybody with the advanced renal insufficiency, it should be avoided, or anybody with abnormal liver function test, just have to avoid the medications. But this class of medication, again, alone, do not cause low blood sugars. They do not cause any weight. Next slide. So this is the last class of medication we will talk during this presentation. Then we will carry it forward like in our next presentation, other classes. So this is called DPP-4 inhibitors. So as I explained earlier, the gut hormones called the incretins. So the way, like for a normal individual, like when we start thinking of food and the food is in front of us, the brain sends signals to the small intestines where these are cells present over there, which secretes a hormone called glucagon-like peptide, GLP-1. So the GLP-1 basically works to increase the insulin secretion and decrease glucagon secretion. So basically that's what you need. When the body is preparing itself for the glucose to come into the system, you need more rapid release of the insulin to cope up with that rise in blood sugars. And then you want to decrease the glucagon because you don't want the glucagon to act on the liver and make excessive amount of more glucose when glucose is already coming from the meals. The one thing with these class of enzymes, like the hormone GLP-1, is that it is very rapidly destroyed in the body. It doesn't last that long. It may last for only 2 minutes. So they are destroyed by the enzyme called the DPP-4. So this is a neat way of prolonging the effect of GLP-1 by inhibiting these enzymes called the DPP-4. So whatever GLP-1 is being made by the body lingers on in the body for a longer period of time and does it what it's supposed to do. So there are numerous medications as shown in the first sentence over there. They are sitagliptin, which is also known by name of Januvia. That is the brand name. Saxagliptin, if I'm also saying the brand name, so you may be familiar with more with the brand names on Glyza. Then linagliptin is called Tradjenta. Then the other one is called the allogliptin or Messina. So these are the 4 drugs which are from this class of medication. They are given by mouth. So basically, as I explained, prolong the action half-life of the GLP-1. Most of them, they have a very favorable, not major side effects. They're very easily tolerable. Can upset the stomach, but very, very rare. Serious side effect is risk of pancreatitis. So if anybody suddenly develops nausea, vomiting, severe belly pain with pain going to the back, they should immediately stop the medication and call the provider. But otherwise, it doesn't cause any major problems. One good thing about these medication, as shown in the bottom, is that dose can be based on the type of kidney damage is there. So stage 1, stage 2, stage up to even dialysis patient, we can use the medication. So this sitagliptin, as it's shown over here, they come in different doses. Saxagliptin, the second one, can be given even in patient with hemodialysis. Next slide. Then there is this allogliptin. There are different doses. It's written over here based on the GFR. That's the renal function. The last one, linagliptin, it's only a 5 milligram once daily dose. And these medications, again, the dose can be varied based on the renal functions. And even in patients with liver problems, this medication can be used. So these are relatively safe drugs. They may not be that effective in lowering the blood sugars, but again, can be used in combination with other drugs to help improve the blood sugars. One thing about these class of medication, the previous one called the sexagliptin or Onglyza, just in one of the studies, there was increased risk of congestive heart failure. So just it's recommended that people with history of congestive heart failure maybe avoid the sexagliptin, but the other medications can be used. So I will stop over here. We will continue with the other rest of the medication during our next presentation. Thank you very much.
Dr. Handal, thank you so much. So, I mean, I say this almost every time, but it is true, so I'm going to just say it again. So, when we pay attention to these presentations, every time there's something that I'm picking up, I think maybe in some cases, I wonder if the patients are really listening carefully when you guys are with them, when they are getting their visits with some of these, especially with the nutritionists, they spend more time with the dietitians. So, because even for us, like when I pick up new stuff, I actually do like controlling the mouse because that forces me to listen carefully, because I'm trying to guess your next slide before you say next slide. So then it actually helps us to focus, and it really does benefit. Like, you know, there's some of the things that I'm going to have some follow-up questions for you later on, not tonight, but when I see you next. But it's really interesting, and how maybe like simple, but at the same time it's extremely maybe complex, and then that's probably why it is difficult to manage the uncontrolled diabetes without the really good team like yourself and the nutritionists. So I just want to point that out.
Yeah, sure. Thank you.
So Amy, would you like me to give you control or?
Oh, sure. So do I have to do anything on my?
All right, I just send it to you.
Okay, so I should be good to go.
Mhm.
All right, so we are completely changing gears from medications to diabetes and the effect on your brain. So diabetes can increase your risk for dementia and Alzheimer's. So we're going to talk about the nutrition part of that and what you can do to prevent it, which I know we're definitely all interested in. So sometimes when we think about keeping our memory sharp, we think about crossword puzzles and Sudoku and exercise, but nutrition is definitely part of it. And a lot of the foods that you can eat to help your brain stay healthy are the same foods that you can eat to keep your blood sugar under control. All right, so I'm not, it looks like.
Yeah, you got it.
Okay, I do have it, okay. All right, well, that worked. I was going to say I'm not moving forward. Oh, there's my things at the bottom. So there is no magic wand. There's no miracle supplement, despite what you see on TV, that you can take this, that, and the other, and this will keep you young forever. Good nutrition has to be a must, along with stress management, exercise, good sleep, taking care of your health, taking care of your blood sugar. We know from research on our Paleolithic ancestors that when they didn't have a lot of food, they didn't have a very big brain. So getting in good regular nutrition. We all know about fish oil, but what else is there? And we're going to talk about specific foods and specific programs out there to fuel the brain. So good brain foods are often good heart foods and good diabetes foods. And starting with green leafy vegetables, kale, spinach, collard greens, broccoli, all things that we should be eating vegetables with lunch and dinner every day. Fatty fish, salmon, cod, tuna, or sardines are really good choices of fish. You want to try and eat fish 2 or 3 times a week. And if you don't like fish, or you don't eat fish, or you're vegan, walnuts, flaxseed, avocado are good sources of good fats for your brain. Berries have flavonoids, which we're going to talk with a little bit later, about what all the different, well, not all the different flavonoids, but about some of them. A particular study looked at berries with women, and actually it was strawberries, that one study in 2012, and only 2 or more servings per week, serving as 1 cup of berries, delayed their memory decline by 2.5 years. So strawberry season, they're good right now. So it is certainly something that's pretty easy to do. You can throw frozen strawberries in a smoothie, have strawberries in a spinach salad. So you're getting in your greens and your berries at the same time. Tea and coffee. As a coffee drinker, I'm always happy to see that coffee has some other benefits in it besides caffeine. Caffeine does have some increased benefits besides just that daily dose. It might not just be short-term with clarity. Studies show that it can keep you going for longer. And coffee is a plant. Coffee and tea both have antioxidants in them, which are really good for your brain. Usually when we talk about coffee, usually I'll ask, well, what do you put in your coffee? And that tends to be more the issue. There are some people who will notice that a cup of black coffee will cause a little spike in blood sugar. Reaction to stimulant. Dr. Hundal can speak about that maybe a little bit later. It's not something we see often, but it is something that you may have noticed. But in general, normal amounts of caffeine are healthy if it's a normal amount, and coffee is certainly good for you. And then walnuts. Walnuts in particular, all nuts are good. Walnuts in particular are very good. So increased walnut consumption does improve cognitive test scores. So other items. So particularly with the fatty fish, omega-3. So we know that omega-3 does lessen cognitive decline. It's even been used to treat mood disorders. Specifically has been shown to help with Alzheimer's patients. So fatty fish, again, flax. Kiwi is not a great source. They do have a little bit, but I wouldn't call it a good source for it. Put some walnuts on it. Eat them in a salad. Eat them with some smoked salmon, and then you can get your benefits in there. So you do want to be careful about taking large amounts of fish oil supplements. Fish is always going to be better than fish oil supplements. Fish oil is generally safe, but if you have any issues with excessive bleeding, you want to talk to your doctor about it. Curcumin, everybody is taking turmeric. Not everybody, but it's pretty popular. It is really best in its natural source in cooking. And it is very popular in parts of the world to cook with, but you can find it today in capsule and tea, and it's better absorbed with black pepper. So you have 2 curcumin compounds in both of those, and it helps the absorption and the efficacy in your body. So it has shown to, a lot of people take it for joint pain, but it also helps with cognitive decay, so delaying that. And then flavonoids. So flavonoids are a compound found in plants, and there are many types of flavonoids. So flavanols, anthocyanins, resveratrol, which is red wine. A lot of people know about that, in dark chocolate. So flavonoids are berries, red cabbage, onions, kale, parsley, tea, red wine, dark chocolate, particularly 70% or more, which is really, really dark. Chocolate is not generally a health food by itself. So the serving is a square. People get excited when I say chocolate. And citrus. So definitely, especially with exercise, they've seen a really big increase in cognitive function with those foods high in flavonoids. So another good thing to include on a daily basis. So what can hurt your brain? I'm sorry to tell beef eaters, saturated fat. So saturated fat is something that may cause damage. So it might promote cognitive decline and worsen it if it's already there. So where do you find saturated fat? It's animal fat, except for fish. So butter, suet, lard, coconut oil, palm kernel oil, fatty dairy, and meat. Some more back to the positive, the B vitamins. B6 and folate are found in most plant and animal products, so you don't usually have to go out and the above. There are people who take a B complex and it may increase memory. If you're vegan, you may need B12 supplementation because it is only found in animal products or fortified foods. So it does live in the gut for about 2 years after giving up animal products. A baby born to a vegan mother needs supplementation immediately because they don't have any living in them. And B12 is something oftentimes people are maybe deficient on with age, especially if you're taking certain drugs like omeprazole and things for acid reflux. And I apologize for the cat who wanted to join our discussion. And vitamin D. So vitamin D can preserve cognition in the elderly. So it's something, vitamin D, we also used to just think of bones, but it certainly does a lot more than that. It helps with immune function and the heart. So sources of vitamin, and the brain, sources of vitamin D are supplements if you really need it. Milk is fortified mushrooms, the way they're grown. And I think my cat hears the thunderstorm. I apologize, she's still in the show back there. Fortified products, those things that are fortified with vitamin D, and the skin of fatty fish. For most people, it's very hard to eat enough vitamin D. So I don't recommend a lot of supplements. I'm a dietitian, I like people to eat, but I often will recommend vitamin D supplements. All right, so antioxidants, a lot of us know. So these work against free radicals, so things that are causing damage in our gut. We talked a couple of weeks ago about the microbiome, and they also, free radicals can cause damage to your DNA, cause damage to your brain. So antioxidants help reverse this damage and they reverse cognitive decline. So more fruits and vegetables, we're talking about vitamin C, vitamin E, beta carotene. When we hear vitamin C, people think, oh, I have to drink orange juice. Red bell pepper has 8 times the vitamin C. So eat a red bell pepper instead. And orange and yellow and green are also good. Citrus, there's your oranges, berries, spinach, broccoli. Most plants have vitamin C. Vitamin E, also very important antioxidant. So asparagus, avocado, wheat germ, nuts, peanuts, olives, and spinach. And then beta carotene is yellow and orange vegetables. So think about carrots, yellow peppers, sweet potato, pumpkin, all good sources. So a diet high in saturated fat. So if I'm going to McDonald's and I'm eating a cheeseburger or I'm eating hot dogs and macaroni and cheese, so we don't have any vegetables, which means they don't have those phytochemicals like the flavonoids, and I have all the saturated fat, it can cause changes in my gut microbiome that can alter my DNA and cause oxidative damage. And that can affect your brain functioning. So that we want to avoid. And so 2 diets to help with this that have been studied. One of them is the MIND diet, which is a combination of Mediterranean and DASH. So MIND is Mediterranean Dash Intervention for Neurodegenerative Delay. That's what MIND stands for. And the studies on it have been shown to slow brain aging by 7.5 years. So the focus on this is 6 or more servings of leafy greens. Remember, that's your kale, your spinach, your broccoli, all that stuff per week, plus another vegetable daily. 2 or more berry servings per week. 1 handful of nuts 5 times per week, olive oil, having some meatless meals, so less, because remember meat has saturated fat, so using a little bit less meat, legumes instead, black beans, chickpeas, kidney beans, cannellini beans, fish once or more per week, and wine is suggested on the MIND diet if somebody is already drinking. If you're on medication that doesn't allow for alcohol, it's not recommended. If you don't drink at all, it's not recommended that you start. But because red wine does have antioxidants in it, this is something, but it's 1 5-ounce glass of wine a few times a week. So this is something when people say, well, isn't it good for your brain, that we specifically specified, not if you are not already having it, not if you have conditions against it. Alcohol will raise your blood sugar. And it needs to be 1 glass, having part of it. And then there's another program that was founded in 2005 at Tufts and Boston University School of Medicine. It's used in senior centers. It's used in nursing homes. It's the Memory Preservation Nutrition Program. It's a really good program. And the goal of the program is to promote brain health and reduce Alzheimer's. So it's generally used in senior populations, and some people already have Alzheimer's, so they're trying to prevent it from getting worse, prevent progression. So the goal is to increase your antioxidants, omega-3s, the anti-inflammatory foods, so things like nuts, olive oil, fish, greens, citrus, reduce insulin resistance. So it's back to our original topic of diabetes. Reduce your bad cholesterol, your LDL, and include vitamins B and D. So those are the big goals of the program. To work on those, they added more plants, less animal products to reduce the amount of saturated fat, whole food, so eating things like oatmeal versus Frosted Flakes, chicken versus hot dogs, hydrated, ideally drinking enough water, probiotics, and then prebiotics, and prebiotics are fibers found in plants, and then limit salt and sugar because we're trying to keep blood sugar and blood pressure under control, and use herbs and spices instead. And then limiting red meat, saturated fat nitrates, which are compounds found in cured red meats, and excess sugar. So notice this says limit. They're not cutting everything out, so you only are eating kale and strawberries and salmon every day. But we don't want to have as much of the other stuff. If you're interested in the Memory Preservation Nutrition Program, they do have a website, which I put on there, which is brainwellness.com. And it is found all over the country. So it's an interesting program. And because there is that risk with diabetes, and I think everybody with or without diabetes wants to keep their brain sharp. But definitely if you've got high diabetes or high blood sugar, if you've got high blood pressure, all things risk for the brain, eating as well as you can is going to help all of it. So how do you implement all of these steps? I always say start really small. I'm not going to expect you to throw out everything, but look to see what you already do. Do you already have some good habits in there? What can you add? Are you not eating any vegetables with lunch? Can you put some baby carrots in there? They don't require any work. All you got to do is throw some on your plate. Can you throw some berries into your cereal at breakfast? Can you have something like bean tacos on Monday and take the meat out just on Mondays? So really little steps, and those are going to build up into helping the brain. So what you should not do is go to the vitamin store and buy all these supplements that have all these compounds in there, because it's always better from food, because the way that food works is the different phytochemicals and nutrients in the food work together, and that they're much better absorbed. When you're taking it in a pill form, it's not going to be as well absorbed. And that is the end for me.
All right. Questions, right?
Mm-hmm. So I have a question for Dr. Hundal. I get a lot. So after the recalls last year with the compounds with metformin, I get a lot of questions about, well, my doctor gave me metformin and I heard it causes cancer. Can you talk about that?
Yeah, I mean, this is again, it's nothing to do with the metformin. This is just the outer coating. They use the other ingredients to make the tablet. So that was just from certain pharmaceutical companies that there was concern. So it was not, it's just every metformin or that was more for the metformin extended release, ER. One thing I did not mention in the previous, since you brought this topic, in some people who cannot tolerate the metformin, plain metformin, we use a metformin extended release. It's a slow release metformin. It is better tolerable as far as from the GI side effects concerned. So there was some problem with those tablets. They were recalled. So this was only from certain pharmaceutical companies. So whenever the patient used to call us, we used to tell them, just call the pharmacist. They'll be able to tell you if your lot number is affected or not. If that's the one, hopefully they got a letter from their insurance or pharmacy, and they will just change to a different formulation for the metformin. So this has nothing to do with the metformin.
Thank you.
Actually, metformin, they're studying in certain type of cancer, and they're thought to be some maybe avoiding prevention of some certain type of cancers, but it's being studied.
Are you familiar with there were some studies a couple of years ago with metformin and Alzheimer's and aging in terms of helping prevent?
These are all like theories. I mean, again, nothing confirmed. It's all, you see a blur here and there, or this one maybe did slow down the aging process, but nothing confirmed.
Nothing, okay.
So one thing I just wanted to bring up, you talked a lot about the different medications and the side effects. Do you find that just because, I have some older relatives, I feel like sometimes if they start to have a side effect, they may just stop taking it, not realizing that that could be worse than talking to their doctor and getting switched over to another medication. So I didn't know if you wanted to mention a little bit there about the importance of being aware of your body, being aware of any type of side effect, and making sure that you either call the pharmacy, call your doctor, talk about that, and see if you do need to be switched to a different medication or adjust the dosage versus just stopping a medication, especially a medication for diabetes.
I mean, that's we see quite frequently. People consult Dr. Google and they will read about all the side effects, and suddenly something happens, they will immediately stop the medication. And a lot of times, as you mentioned, they won't even inform their providers. So it's important to, first of all, it's the responsibility of the providers to explain to them the possible side effects, so patients are better prepared what to expect. Certainly, for example, with metformin or certain drugs, initially they may be mild stomach upset, but as you continue medication, majority of the people, it goes away. But if you don't tell them, they will stop the medication. So as a provider, we also need to do a better job. And then as a patient, they need to be aware of the side effects. And then if something serious happens, obviously immediately stop the medication, get in touch, but don't stop medication of your own or read over the internet, or this causes cancer, or this causes, like, for example, with the kidneys, we see it all the time, patients coming, oh no, metformin causes kidney damage, I'm not taking it. So they will let their blood sugars go run high, and ultimately a lot of these complications are as a result of poor control of diabetes. They keep on, no, I don't want to try this drug, I don't want to try this drug, because I read all the side effects. Those side effects are not that common. I mean, as part of the FDA guidelines, they have to mention all the possible side effects which can happen. It's not must that every person will get all those side effects. Even if you read the side effects of aspirin or Tylenol, I mean, you won't take the medication. That doesn't necessarily mean everybody is having those side effects. So it's very, very important to stay in touch with your providers and immediately tell them if something is not improving, definitely get in touch with them.
Thank you. Yes, that's what I wanted that emphasis on, because as you mentioned, the disease, the diabetes, that's causing more problems than the potential of the minor side effects. So that's what I just wanted them to understand, the importance of the glucose control.
And plus they're on a lot of medication, just not diabetes. They are on cholesterol medication, blood pressure medication, aspirin, some other heart medication. So sometimes they can be drug interaction and some problems. So always good idea to touch their base with their family physician providers, whoever has prescribed the medication, and talk to them before taking their own step.
So I have one, maybe re-emphasizing the comment that I was trying to make earlier. And then I just posted underneath our live event. So the gut and the brain connection and understanding how they are kind of working bi-directional, I guess, in a way. So everything that we do before it happens, even though they are not directly connected, but they are signaling. I think there are a lot of maybe learning points for the patients, just to kind of maybe in simple terms to better understand that connection. And if there's any way that, like for example, in many cases, right, Dr. Handal, like if the patients lose weight, if the need for the medication for those patients with diabetes, the need for medication is going to be less if they lose weight. So,
right, that's true.
And if we are able to maybe kind of, I'm thinking maybe Amy, Donna, we can talk to Dr. Handal later on, just to put some more maybe simple diagrams to better explain the connection and what happens, because many people forget, like if you have a stomach ache, in some cases, we forget what may be happening and then we are looking for some reasons for that, but it may be just simple stress, right? So then the eating disorders kind of makes it a lot easier for me to actually understand as I'm listening more and more what you guys are telling us. So I do believe that I can make certain changes in my own life or my own diet throughout the day. That does help.
Yeah, I mean, that's why I mentioned, like the previous presentation also, we mentioned diet and exercise and weight loss. I mean, these are the key components of any diabetes treatment plan. You can't bring your diabetes under control without doing the first three. Sure. So some people cannot lose weight, maybe multiple reasons, joint problems, other things. So it's not like if everybody could lose that weight, there won't be any diabetes to start with. But not everybody can do that exercise.
Oh, I'm sorry, I didn't mean to interrupt.
No problem.
What I will usually tell people is sometimes they're very frustrated they can't lose weight, but you can still help your diabetes by eating well. Even if you might not lose weight, if you fix your nutrition, and balance meals, you may only lose a pound or not lose weight, but your blood sugar could be better. So, you don't have to give up.
Yeah. I mean, another thing very important, like regarding your diet too. I mean, a lot of people, I mean, thanks to you, like you teach them well. Like a lot of people don't have any idea about the portion control. They still think, okay, I'm eating healthy food, but healthy food, like they will fill up their whole full plate. Oh, I'm eating salad, I'm eating this, there is a chicken there, there's pasta there, small pasta there, but the portion size is so big. So I think that's where your guidance really helps them a lot. And second thing is with the general, as providers, we quickly tell them, oh, you need to exercise 30 days and 30 minutes a day, 5 days in a week. So that the statement which they hear all the time, a lot of people cannot walk or cannot do exercise for 30 minutes. And they just don't do exercise. They say, I can't walk for 30 minutes, period. They don't think in that way, okay, maybe I'll walk for 5 minutes. No, my doctor told me 30 minutes. And a lot of times people, that's what they tell me. Then they usually have been started doing more to tell them, okay, I don't need 30 minutes at a stretch. I just want you can break it up. I want the total duration of your exercise should be 30 minutes. You do 5 minutes in the morning after your breakfast, 5 minutes in the afternoon, just make it up, add it up, and it should be 30 minutes. So in that way, oh, you're really okay. That we can try. We can do for 5 minutes here and there. But a lot of people of the older population, they have joint problems, knee problems. You tell them 30 minutes, they never do it. They say, no, I can't walk. And that's the end of the story for them. So slowly, education is very, very important.
Agreed. So Amy, just to give you a little spoiler, so the garden is coming up. I'm taking pictures as we are progressing more. Can you see it? So the first stuff are coming out. So like this is Dr. Handal, this is going to be one of our sessions, I think, in June. So we are going to discuss like how easily actually you can get some fresh vegetables.
Vegetables. Oh, nice.
So, and it's almost effortless, almost.
Good, good.
We just picked our first vegetables this week, our radishes. So we have a whole bowl full downstairs. So that's our first crop.
Well, that's, I had with dinner, I picked some tomatoes and some basil off the deck. And that was part of my, I made little caprese salads. It was good. So our next, I think that's actually in July, come on. Our next webinar is with Celeste, our diabetes nurse, well, she's not a diabetes nurse educator. And that is going to be June 9th. That was supposed to be tonight, but we rescheduled. Thank you, Dr. Hundal, for joining us again. And we are going to be talking about continuous glucose monitoring systems at that next one, and carb counting.
So Dr. Handal, someone wants to say hi to you. You haven't seen him.
Oh, yeah. How is it doing, buddy? Yeah,
He's doing good, but look, there's Dr.
that's
Handal.
great.
So, as you guys were hearing the heavy breathing that was coming from Buddy. So, well, guys, thanks so much. I know this was at the end of the day, long day for everyone. We really do appreciate for you being available and educating us and answering questions. So we'll be back in a couple of weeks. All right. Thank you.
Thank
Good
you.
night.
Okay, bye-bye.